So Peter, I think it's important that the orthopedic surgeon has to have a good conversation with the patient on what type of treatment plan. And I think a key factor for me is the patient should be shown their x-rays and they have to be realistic of what we can provide for them.
Oh no, I want a cure, I want a cure today. I saw it on TV.
The most important, the patients come, I want to be like when I was 20 years old. I want to be able to do this. And you know, the first thing I said to them, I said, you know, no matter what I do, whether it's surgical or non-surgical, you have to be realistic. We can't make you the when you were 18 years old. But we can help you with your symptoms. And if they have terrible end-stage arthritis and we've exhausted all the non-surgical things, we can help you with knee surgery. But again, it's not going to be a normal knee. And I think that's where a lot of dissatisfaction comes up. People are unrealistic expectations.
So Peter, we did a lot of work on this, and we came up with the term modifiable risk factor, looking at a patient's risk profile as it pertains to their operation. And clearly, as Andrew said, if you're diabetic, you're morbidly obese, you smoke, your risk of infection and complication after knee replacement goes up astronomically. And these factors are multiplicative, they're not additive.
Now, again, I come back though, don't you hear this all the time? I don't want to do anything, I just want you to fix it.
Let me get back to this. So the whole point of this then, we then applied those characteristics to patients preoperatively in the thought that, listen, if we can help you understand what your risk is for operation and how these risk factors increase your risk of needing a joint replacement, perhaps we can modify them before the operation. And that's what part of this arthritis education website is about. The important thing is to join in the patient in a shared decision-making discussion and identify the risks for them, that what their health status does to them as it pertains to arthritis and the risk of operation. And then the key part, as Paul said, is expectations. Well, what do you want to do? Do you just want to walk to the refrigerator and get more Twinkies out? Or do you want to actually participate in exercise and improve your health status? Then the key is to engage them, right? If we've shown that if they engage, if they do anything, it doesn't even matter if they completely stop smoking or if they just lose 10 pounds or if they do some exercise, that improves their ultimate outcome.
By the way, I'm not sure you need to put Twinkies in the refrigerator, but that's another issue.
True.
The frozen ones are great. Anyway.
But buy-in is what you're talking about.
They have, if the patient has to have skin in the game. We can't just be technicians and provide them with replacements, because if their expectations aren't defined ahead of time, we'll never be successful.
You know, one of the things we've learned as well is that the expectations have a lot to do with ultimately patient satisfaction. And if those expectations, if we don't understand them and they don't understand them and they don't understand the limitations of what we as surgeons can offer them in terms of satisfying those expectations, their outcomes and their satisfaction is not going to be as good.
I mean, that's what I want to get back to, is that even the perfect artificial knee, total knee, is not a normal knee. And I think patients have trouble.
Oh, they don't want to hear that.
They don't want to hear that. They want to just be normal.
I mean, they want to reset the clock, right?
Right.
Oh, good, I've got a new knee, so now I can gain weight because my knee's better. We can start from ground zero. And I can also run the next 10 marathons.
Well, I think that there's ample data in the literature, and we've reproduced that as well, that suggests that patients who say to their doctors, well, fix my knee and then I'll go lose weight because I can't exercise, they don't. You look at them a year later, their BMI is unchanged.
I actually did a study of that too. That patients actually gain weight after a successful total knee.
Why?
That's been reproduced.
Well, people as they age gain weight.
They gain weight.
It's about 10 pounds a decade.
Yeah, it's.
But really, I mean, you give them a knee, they can go out there and move better, and you would think, I mean, to the
in their mind, they think they're still 38 years old. They're 65 now. They're 70. They are not 38 years old. The rest of their body aged too. They have I liken it to a good used car. A knee replacement, we didn't replace your knee. We resurfaced your knee. The rest of you is still 65 years old.
Do you want undercoating with that? Or? I mean, seriously, people have unrealistic expectations.